I want Anu and Nalini to be my respondent. Some of the photos I'll be putting on, I think you should answer. Both of you are young and dynamic. I think you should be able to answer in time. Yeah.
Vageesh, you're not allowed to quiz her. She's the chairperson.
Yeah, no, just as part. Okay, right. I think next 25 or 30 minutes, the endocrine neuropathy. I'm not going through the details of the text. I think it can be done in the internet search. But what I have gone through this endocrine neuropathy cases in my past 16 to 20 years of training and faculty at St. John's, I'll be posting that I'll be talking on. So we know that hormones affects all organs and nervous system with no exception. Each and every organ gets affected. So even broad range of neuropathy and neuromuscular symptoms are found in endocrine disorders. Though all endocrine systems are important, but diabetes sweeps the literature because of a sheer number and economic impact. But in my presentation, I kept it only a last few slides on the diabetes. Rest of it will be mainly on the endocrine system. We'll move to the hypothalamo-pituitary disorders causing some nervous system dysfunction. This is mainly because pituitary stays very close to the cranial nerves and also the optic chiasma. Hence, most of the time, enlargement of the pituitary presents some of the dysfunction. So these are the visual things what we'll be getting when pituitary enlarges, and depending on a chiasma which is prefixed or a postfixed, and we'll get lots of findings right from optic atrophy, bitemporal hemianopias if it involves the optic tract. So this was a patient of acromegaly. He didn't look so much acromegalic, no gross, but most of the time had lots of symptoms in the hand, what we call it as a carpal tunnel syndrome. A huge tumor with some amount of a visual defect, but the functioning hormone levels were not that big, but the symptoms were more in the hands. So carpal tunnel syndrome is the one which is quite commonly seen in acromegaly, including you can see a thickened nerves. But sometimes these acromegalic patients can present with a sudden cranial pulses with severe headache. This is what happened with one of our patients, Arogya Mary. You can see huge pituitary tumor with apoplexy. She presented to the emergency in almost altered sensorium, and the CT done by our emergency staff showed there was a apoplexy. She presented with various cranial pulses. So the carpal tunnel syndrome is the most important thing when it comes to the acromegaly. About 50% of the patients do have this, and subclinical nerve conduction abnormality is seen up to 80% of asymptomatic patient. Means almost most patients with acromegaly do have this symptom. Effective treatment most of the time resolves within 6 weeks, and we know that we don't have an effective cure in acromegaly. It takes years to come under control. Even it has got lots of neuromuscular effects like proximal myopathy, mainly because of atrophy of type 2 muscle fibers. This was one more our acromegaly patient who has a huge tumor, presented with bloating of the sensation and also in constipation. When we did a barium swallow, we found there was a megaduodenum. This megaduodenum is seen even with congenital cases and acquired cases, mainly because of a gangliosis, which is commonly seen, and some amount of autonomic neuropathy, which has been described in some patients. We thought it's probably because of the autonomic neuropathy associated with acromegaly. So this we published in IgM and also in the conference. This was a patient who presented with a cranial pulses and a severe headache, had a huge tumor, and this was a case of a tuberculosis which was masquerading as a pituitary adenoma, and it is quite, though it is rare, we do see in our clinical practice in India. So this person came at 23 years with very sparse hair, that too following certain treatment, and he was having a difficulty in hearing. Any clues on this patient? Yeah, it was a patient of a suspected Kallmann's. Many a time Kallmann's do have some cranial neuropathies, especially the visual and auditory, but some patients will have what is known as a mirror movement. This is one more person who presented just 15 days back to our OPD. He had a difficulty in operating his computer, mainly because of his mirror movement. he was unable to do with the two hands, and this is a mirror movement what we see with Kallmann syndrome. Yeah. So this patient had just an anosmia with a lack of uh, mush and a beard, came for a secondary sexual characters, and you can see in a MRI, especially if you take a frontal sections, absence of a olfactory tract and olfactory bulb. So these are the typical neurological features what we see in a patient with a Kallmann. So this is a case. I think this was referred to us from Niemann's. This is one of the very, I think, famous institute which is very close to our institute, and rarest of the rare neurological cases sometimes gets referred to us for the endocrine evaluation. And this was a video the father brought along with this patient. She was referred for a specific endocrine abnormality, and the diagnosis was gelastic seizures. So this child did had a gelastic seizure and a hypothalamic hematoma, and we started her on a treatment and sent back. Yeah. So this was a one more child which came to us with a short stature and a lack of secondary sexual character. She had features of a pan-hypopituitarism or a combined pituitary hormone deficiency, but what was evident on the eye was a coloboma of iris, and these are the cases they have even a coloboma of a optic nerve also. This is one of the clue for looking for the coloboma of a optic nerve. Yeah. So this was a 14-year-old diabetic patient, type 1 diabetic patient referred to us for an evaluation, mainly because he has got a poor visual outcome. When we focused closely on his eyes, we found that his pupil was quite dilated. There was no effort required to look into his fundus. And subsequently, we had a finding and referred to the ophthalmology for a confirmation. And he had, I want some response.
He had pseudo-Argyll Robertson?
Yeah, he had some amount of part of pseudo-Argyll Robertson, and he turned out to be a Didmorden. He had a Wolfram syndrome. So all those years he was treated as a type 1, but the moment he got admitted for evaluation, turned out to be a Wolfram case. And subsequently, his diagnosis changed and went back with the Wolfram. This is one of the some in the first decade, these patients do have a diabetes and optic atrophy. Subsequently, they have a DI with a 1/3 of the patient having a DI symptoms. Most of the time, they have a gonadal failure, renal outflow tract obstruction, reduced nerve fibers, and a progressive atrophy of the nervous system. And sadly, this patient subsequently committed suicide at a native place and didn't turn up for a follow-up for a long. Okay, this is a one more child which was brought from the mother because of excessive growth, and the diagnosis of acromegaly was evident, but there was no tumor, and started losing vision progressively. So, any clues on this patient? Yeah, I think next patient will make this diagnosis very clear. I think this is a one more case which had a similar finding, but he had a very clear-cut diagnosis on the face. This is a McCune-Albright syndrome with a fibrous dysplasia involving the optic nerves, causing blindness in both the patients. Yeah. So I think this completes our hypothalamo-pituitary. We'll move to the next system. Just I want one audio clip, and I want to identify which system we are dealing with. This was taken from one of our patients. Yeah, this is a continuous bruit what we hear, and the continuous bruit we hear in our patients, mainly with thyroid disorders, that is a Graves' disease. So Graves' disease do have lots of neurological manifestations, and what we commonly see, the thyroid-associated arboretopathy more commonly seen in Caucasians, but we Asians, we see more of a DON. There's a dysoptic neuropathy associated with the thyroid diseases, wherein the shallow orbits with the crowding of the muscles at the apex leads to the sudden loss of a vision, and this is an emergency wherein we have to administer the treatment which has been already highlighted by Dr. Nalini. Yeah, you can see that crowding of the muscles at the apex, and this patient had a sudden fall of vision, and he has to be admitted and administered emergency treatment to bring it back his vision. Yeah. Other thing which can present in thyrotoxic patients is an hypokalemic periodic paralysis, quite rare in Western countries, quite common in the Asians, occurs predominantly in the males with certain linkage to the HLA antigens, and the signs of a toxicosis may be very mild, but these symptoms may predominant. We had a share of these cases. We had 10 patients of hypokalemic paralysis with a thyroid association. Almost in our case, 70% were males, 30% were females, and we presented this in our National Medical Journal in 2011. And rarely the thyrotoxicosis can present with a bulbar myopathy, when dysphagia becomes difficult and patient might come with the aspiration of a foot. Most of the time, these symptoms resolve completely, and once they become a euthyroid. So we had seen one patient way back in 2011 when I was working along with our medicines colleague. We presented in a JAPI, whereas thyrotoxicosis presented as an acute bulbar palsy. After the treatment in 3 months' time, patient improved completely. So this is a straightforward hypothyroid patients, but many a time they present with muscle hypertrophy, and they also present with what is well-known phenomena known as a hung-up reflex or a Cocker-Semelinet syndrome or a Hoffmann syndrome. Carpal tunnel syndrome is one of the most important. 1/3 of the patients with hypothyroidism can have it. And if you screen all carpal tunnel syndrome, 10% of the unselected cases belongs to the hypothyroidism. Then we'll move to the calcium disorders. So the young boy who came from West Bengal, he was carried in the stretcher because he couldn't walk, because he had lots of bone pains and fractures. We know that patients with hyperparathyroidism do have some amount of CNS and neuromuscular manifestations. He had one adenoma, and his bones were suggestive of a HPT picture. And we had a big series on a primary HPT, and it got published in IgM way back in 2018. And in our series, we found that up to 40% of our HPT patients had a neuromuscular manifestation in the form of weakness and a bone pain, and up to 10% had an encephalopathy and a seizure. One patient came in a coma and recovered the moment the tumor was removed. So this was same patient after 1 year came walking to our OPD. So this old lady had a goiter because of the cosmetic reasons or because of the doctor's persistence, underwent removal of the goiter, and she presented with the photo next to her. That is the tetany. This was our young boy who had an thalassemia. Because of repeated transfusion right from the childhood, he developed hypoparathyroidism, presented to the emergency with the tetany and seizures. This is a boy who came from Northeast. Mainly think he had some abnormal movements, and his physical features were suggestive of a AHO phenotype and pseudo-hypoparathyroidism, and his CT was suggestive of a basal ganglion calcifications. Coming to the next system, that is adrenal disorders. So the young child diagnosed as Addison's disease. Almost all the lab parameters were suggestive of Addison's disease. We started treatment. Most of the time, very frequently, this child used to get admitted with a recurrent vomiting. So his admissions were so frequent that, and we thought his short stature is mainly because of the poor compliance, and is getting admitted with the adrenal crisis. Till he went to one more endocrinologist. He thought that the only treatment for a short stature is a growth hormone. So he prescribed him a growth hormone. The parents came back to us with a growth hormone prescription. When we analyzed and we looked into his problem in detail, we found that he had achalasia cardia, This achalasia cardia was operated upon, and subsequently his compliance improved, his vomitings reduced, and he started improving well. And this was a case of Allgrove syndrome. So this 4A syndrome is because of alachremia, achalasia, Addison's, and autonomic dysfunction. Autonomic dysfunction is the neuro part of the Allgrove syndrome. It is associated with variety of progressive motor, sensory, and autonomic neurological defects plus middlecorticoid deficiency. It is an autosomal recessive condition with one protein defect known as an Aladdin. In the diagnosis of this patient, we had one more case of Allgrove's disease. This young girl walked into our OPD with features suggestive of Addison's. She was referred to us from the dermatology. As this was an Addison's case, we asked for a CT of the abdomen, and our resident, Dr. Madhuri Patil, in a hurry, in a busy OPD, in a hurry, instead of writing the abdomen CT, wrongly she wrote the CT chest. So that made the diagnosis of this patient. On a CT chest, there was a dilated esophagus, and the diagnosis of Allgrove's was made. Fine. So we're coming to the last part of the presentation, that's the diabetic peripheral neuropathy. I know each and every day and in and out we'll be seeing diabetic patients with a diabetic peripheral neuropathy. Mainly they present with diffuse neuropathy, mononeuropathies, and also radiculopathies and polyradiculopathies. But our interest mainly with autonomic or cardiovascular things. We did work on this to some extent. This was our work which was published in IGM way back in 2011. It was an autonomic nervous system function in a type 2 diabetes patient using conventional clinical autonomic test, heart rate, and blood pressure variability measures. And we found that compared to the controls, our diabetic patients had a significant defect in both sympathetic and a parasympathetic nervous system involvement, suggesting we need to look into an autonomic nervous system in all patients with a peripheral neuropathy. This is one more imaging. This imaging from our close specialty, that's a gastroenterologist. This was a patient who came with a recurrent hypoglycemia, and on US endoscopy, the insulinoma was picked up. Then with the enucleation, patient became all right. Patients with insulinoma also can present with lots of neuropathic symptoms. We did had our series and got published in 2017. This was an endogenous hyperinsulinemia. We had 16 patients. 14 patients were an insulinoma patient, and 3 patients were autoimmune hypoglycemias. And almost 100% of the insulinomas had autonomic symptoms. So suggesting even an insulinoma, if it is prolonged for a long time, they do come with autonomic symptoms. In a long run, there can be a neuropathy, but we have not tested them following the treatment. So this is my last slide to thank all our SRs, with the Belinda being on the top, with Nalini being in the middle. So, and also my co-faculty. Without them, we wouldn't have got so many publications and also a patient for our presentation. Thank you.